To just give me a brief allude to who I am, I work at the American Mission Hospital, which is a non-for-profit hospital. It's a secondary care center based in Kingdom of Bahrain. It has been in existence for the last 120 years and shortly will become a tertiary care center. By training, I'm a general and a laparoscopic surgeon. At the present moment, I wear multiple hats in the hospital. I'm a chairperson for the infection prevention and antibiotic stewardship. I'm a member of the quality team, the clinical effectiveness team, and the credentialing and privileging team, and an absolute infant in healthcare quality. But I'll try to best to share my experience as well as take along you the journey of how to engage the physicians. There are two key performance individuals who have made a lot of impact in my presentation and in my healthcare quality journey. The first is Dr. Tenarasu, who has initiated me into the CPQ HQ system. He has mentored me, and really humbly thank you very much, sir, for guiding us. The second person is Dr. George Cherian, who is our corporate CEO, who speaks and reads quality, who gave us the initial thing for quality, and that's what has initiated me into this journey. What I have used as resources for my presentation today, this is a list of resources. I've used the IHI articles, I've used the American College of Medical Quality articles, and the Canadian Journal of Physician Leadership. This has been the basis for what I have been reading through. These are my resources. I've already gone through them. Now, all of us are aware of that landmark article which came to err is human and crossing the quality chasm. Now, this is the basis for a whole lot of our rethink how to improve healthcare quality. As of 2016, as per a study by John Hopkins, medical errors are the leading cause of death after cancer and cardiac deaths, about 250,000 deaths per year. And as of today, WHO has estimated there are about 134 million adverse medication events which occur in low and middle income countries. Now, all this has to be preventable. To prevent that, we need to have what is called an improvement in our process system. So a performance improvement process is what is required along the entire healthcare sector. Now, throughout the health industry, it is widely recognized that physicians are the backbone. And physician engagement is the key factor for better outcomes and productivity, improved satisfaction and commitment. A Gallup survey has said a key and engaged physicians will have about a 26% increase in productivity, and that's a good benefit for all the organizations across. Now, there have been definite strategies which have been studied and are effective for engaging physicians in the performance improvement process. And these are discover common purpose, reframe values and beliefs, segment the engagement plan, use engagement improve methods, show courage, and adopt an engaging style. Now, to a large extent of my life, I have been a clinician and a physician. So engaging a physician is very critical. And many of us as physicians, we don't accept the change so easily. But coming into quality, I can see that engaging the physicians is very, very important. What is the common purpose that you see in the performance improvements? And the areas which you need to look at is you have to outline the patient outcomes that you want to improve. You have to reduce hassle and wasted time. Time is very crucial for an active clinician. You have to understand the organization culture in your own particular setting, and you have to understand the legal opportunities and barriers for the physicians in their practice. Now, many of these time-tested process are varied across the organizations. Now, each organization is different. You might be working in a tertiary care, an academic center. You might be working in a small health sector, as I've been working in a secondary care center. So each of these benefits are there across all the organizations. Time management is very important. You have to reduce hassles. As a physician, what I don't like is having too much of documentation, searching or tracing results, justifying insurance claims, being members of various committees. That takes a good effort of my time, and legal and medical certifications. These are actual time stealers from the actual patient care and patient-physician relationship. If you have a good outcome, all these time stealers have to be removed from the process. Each organization is different. So when When we are planning any performance improvement process, we need to understand our individual organizational cultures. Now, given that now we have a wide scenario of organizations, might be differential employment contracts. You might have an employee or a doctor who's full time in that organization. You might have physicians who are part time, or you might have physicians who are just visiting consultants to various hospitals. So, all their requirements and their commitment to the organization might vary. Now, each of the individual physicians might have different beliefs, norms, and values. The training might be different. So, given on that, you have to find a common ground to talk and negotiate with the physicians. And very important when you're starting an improvement process, you have to know the history of the past initiatives or endeavors. Successful, they will move very forward. But if something has failed, that will lead a very bad taste in the mouth, and that has a lingering after effect. And that will not prompt a physician to come on board. Legal opportunities and barriers. This is more relevant to hospitals, especially in states and corporates, where it is hospitals where you have visiting physicians. Now, as per legal requirements in US, you're not supposed to pay any initiatives to the visiting consultants, but that is against the law. So this does not have a direct influence in our today's outcome, and it is more related to whether we're giving a financial outcomes over performance outcomes, not relevant to our today's topic. The second thing which we have to relook at as to engage the physicians is reframe values and beliefs. Again, as a quality initiative person or as leadership, you have to make the physician as partners, not just treating them as a patient or a customer. This will make the physician feel engaged in the process. And again, this is more applicable to visiting physicians. And this also is important because especially where you have an organization where you have full-time employees with visiting physicians, you have to find a common ground to improve a process. A very important thing is you have to hold people as well as the systems accountability, give responsibility to improve the outcome. Now, the physicians as such, they are ingrained with a very deep sense of self-responsibility. And an important critical factor which is very often overlooked is that we as physicians have a very poor understanding or even basic knowledge of system science, which is very important in a recognized science today. Now, when you're having a common background, when you're starting a new performance improvement process, it's very important to share stories across all the teams. You have to share what happened in the background, how you failed, and what are the factors which made you fail. And you have to discuss even outcomes which, even if they are small, share with among all the teams. And this has to be very candid. The third strategy is whenever you're trying to engage the physicians, if you give them too many ideas or too much workload, they will back out. So you have to segment what you're proposing. You have to prioritize the physicians and you have to sequence your work. Need an absolute engagement from the physicians. If you are making a new guideline, something related to patient care, to patient safety, the physician has to be on board from the beginning. Something related to workforce planning, compliance, education, they are required. Sometimes in marketing or community outreach, they can give you helpful hints. But where they are not required, we should not have a wastage of their times, especially in vendor contracts, deciding about furnitures or parking. That areas physicians don't come in. A very critical part is once you have a process, have a meeting with the entire teams required and identify key people who have good courage and who have social skills to negotiate, to have a good communication with almost everybody, make them as a champion. This does not need to be a titular or a structural leader, but always take into confidence the titular or the structural leader, because if they are not engaged, you might have administrative problems. And as physicians, many of us have big egos. So what happens is the titular or the structural leader might not cooperate and feel that he's been not taken care into consideration. Now, as a general rule, if a performance improvement process is going to require physician to change something in order to write or to adopt a new or developing new policies, or if it affects their daily flow, it requires physicians to be 100% committed. So engaging with the physicians in any performance improvement process is very critical. All of us know any process will have people who are the innovators. We will have somebody called early adopters who are very flexible. When you talk to a champion or an early adopter, you'll see a glint of gleam or be enjoyable about the new idea. These are the guys who will be forward. And if you share valuable data, tell the process mechanism to them, these will people will become the champions for your cause and for the performance improvement. But at the same time, identify people who will make a retard in your process systems. These are called the laggards. And mind you, many of their times, these people who give their feedback in the committee is important because they will make you aware of where your process or your structure will fail. These guys have an insight of a negative. They are always going to question where it is going to break down. So take their opinion early. This is a Mr. Abraham's pyramid of how human psychology works. We accept everybody, every doctor to reach a level of self actualization, but that's very difficult in surgeons and physicians across. But somebody whose esteem, psychological needs are well looked after, these are the guys who can make a lot of difference. So identifying that type of a physician is very important in the initial phase. When you identify a critical physician, a champion, or a leader, think how you can maximally use that physician's time, his effort. You have to provide a timely, credible data to this physician so that he can communicate with his peers. You have to assess whether this physician requires any further training or development in that actual process. He might be eager, he might be passionate, but he might not be knowing the subject matter. So training him is very important. And the most effective thing is having an effective communication across all the stakeholders. You might have a performance improvement process which includes multiple departments. So you have to identify key departments. All the stakeholders have to be taken on board, and you have to give them credible and candid communications. The next one is how to use engaging improvement methods. Now, whenever we want to do something, we'll try to standardize it. And when you're going to standardize it, keep it very simple. Whatever can be done very easily, start with that. If you have a detailed protocols with multiple side branches requiring a lot of strict compliance, the physicians will back out because they will feel there has been a wastage of time. They would not like to get into it. So identify a process which can be easily given a simple standard, accepted standards are available, evidence is present, start with that. Use terms for the physician which are very important that your patient will do better. We will have an improvement in your outcomes. Your time will be saved. Use these terms which give a very positive vibe to the physician, and you can have your system move forward more easily. Try to keep the standardization very simple. As I said earlier, no multiple branching. Try to use the best medical evidence across. Learn how your systems work. Even before you share knowledge, try to think of things where your systems will break. So you're ready to understand, this is where the physician will ask me a question and I can tell how my system will work or not. And anything, start on a small scale. Maybe we start with a small team, a small department, or a small part of the hospital and see how it works. And be ready to change as soon as possible so that you can have a better outcome. Whatever data you collect or whatever pre-existing data you have, use it very sensibly. Physicians are very sensitive. We generally don't like somebody coming and telling us, hey, this has happened, that has happened. And we are very not happy to listen to data from other sources. So be careful how you present your data across. And as a physician, even including myself, whenever we given a data, we think, this is related to my individual performance. So many of us, we do not recognize that safety and quality data elements are not attributes of individual performance. We take it very personally. So engaging the physicians and telling them that, hey, these are system things. This is, if you change the system or if you improve the process, our outcomes are better. That gives a better trust and confidence building measure with the physicians. Whatever you're planning, it should be easy to try. Now, any physician, you give them a change, we are tuned to think it as risky. And many of us, we will go into a group and huddle and think about the pros and cons. This is where the early adopters or the champions will come in, and will they make a difference, because they will be talking to their peer group, they will be presenting their communication, using their communication skills and courage to take the team forward. Actively look into the system, be very sensitive where you can fail, and be very sensitive that how much time consumption or is there a hassle to the physician. If there's a lot of wastage of time, or if they perceive that this system or a performance improvement is not going to work, people will back out. Physicians don't like to take a risk. They don't not like to waste their time. So as I said earlier, test on a small scale and see if it is cumbersome. You feel it's cumbersome, our systems are not geared up, physicians will back out and they will not be on board with your thinking process. As I said, and to quote Mr. Edward Ziming, a bad system will beat a good person every time. So even if you have identified a good champion, a good leader, but if your system is going to fail, the physicians will back out. And that's very important before we identify which performance process has to be improved. Showing courage. This is more relevant to leadership, the top management, as well as people who are going to lead the entire process. If there are mixed signals given by the leader and there is no commitment to a process system which is going to be improved, physicians will lose interest. If you're going to give multiple ideas from the top and expecting all ideas to move at the same time, again, physicians will lose interest. You cannot engage with physicians on multiple processes. So keeping it small and keeping the standardization easily is very important. But at the same time, red lines have to be drawn. You cannot have all the physicians going on in different directions. Certain things have to be agreed at leadership level and you have to move forward. At the same time, it's very important to understand organizational silence. A lot of topics are not discussed in the committees. There might be an elephant sitting in the room about a particular problem, about a particular physician or a particular surgeon. That has to be candidly discussed by the leadership along with the involved stakeholders. And the last strategy, which makes a lot of difference, is how to adopt an engaging style with the physicians. Now, you have to understand the physician's mindset. Each of us been trained in various systems, and this training ingrains as a hard-won immutable values. All these are values are very difficult to change. We would not like to have any change in our system, in our working style, in our thinking process. So anything has to be gradual. All physicians have this daunting consciousness that they bear a daunting, life-changing personal responsibility to the patient. So everybody is worried about their outcome. They don't look at the system improvement as a big part of their responsibility. There is a strong sense of collegiality. Physicians, as anything, any risky effort will group up. They will debate a lot about the pros and cons. So you have to understand taking a group of physicians on board is very important. Identifying that key champions for that process improvement is important. Credibility of the data, what you present across, is very important. And with the recent onset of so much of malpractice, there is a serious paranoia among physicians about malpractice liability. This will lead to a lot of unwanted resources to being wasted in terms of extra processes being done or extra investigations being done or unnecessary surgeries. So this has to be understood before we come into a performance improvement process. A critical factor is involving the physicians for the beginning. You can't give a half-baked idea or a partial developed idea and expect the physicians to work on it and bring outcomes. No, the process has to be very clear. And you cannot bring a similar process or a setting from another hospitals and use it and say, hey, that is applicable there, let's do it out here. No, you have to have a rethink on it. You have to look at the exact step of all the process, see whether your system can gear up and see this process can be done. In our hospital, when we started the antibiotic stewardship uh, program in our hospital, the first thing which we quality initiative we took was of the use of prophylactic antibiotics. And unfortunately, when we started the process, we didn't take the anesthetist on board, and that hit us really. It has took us about 4 years for the anesthetist to really come on board, and then only we could make it a 100% success. So involving the physicians from the beginning is very important, starting from the planning process. Any process, any group of physicians, any group of individuals, we know there will be innovators, there will be early adopters who are absolutely early in the process will start the change. Then there's the early majority which moves along with the early adopters. There's a late majority and their laggards. The person who's an early adopter is the guy who can be made a champion. They will enjoy and embrace the change. They will have a glint in the eye when you talk about the change that you want. And these are the guys who will influence the early majority and the late majority to move. But at the same time, as I said earlier, think about the laggards also. These are the guys who will tell you the negative things, and that will make your process systems more better. Sending out the right message, and the person who sends out the message is again important to the physicians. If you have a non-credible physician or a physician who is not involved in the process, acting as a champion or taking out the improvement process and doing the work, the other physicians might not follow. So initially at the state, at the planning process itself, identifying the key individuals is very important, and what they would share with the group is also very important, because what is stake at this time is the credibility of the entire performance. And if this is absolutely correct, there is a good amount of building about the trust in the team members, and you will have a whole lot of people moving into the process very faster. Another critical point during the planning and the early stage of the improvement process is acknowledging physicians. Many a time in larger settings, you'll have the managers who will take the credit for starting it, and the physicians are left behind. We have to understand only a few physicians would be involved, but acknowledging that physicians regularly and starting from the planning process makes a lot of difference. It builds up trust among stakeholders. As I mentioned earlier, building trust is very important. And when you're looking at the organization culture, you have to look at the history of how the past performance improvement processes have gone about. And especially past failures linger on. They leave a bad taste in the mouth, and they're not easily forgiven by the late majority and laggards. Laggards are the one who will pull your system down. Having an 100% improvement in your outcomes is very important. And if you don't take the laggards on board in the initial meeting, you might face difficulties. Your communication to your teams, especially when you're identifying a new process or changing the process, has to be very candid. It has to be frequent. It has to be decided on a day to day basis what you want to inform the people. And especially with physicians, interpreted data leads to a lot of mistrust, because you're expecting a judgment from another person. So as a physicians, we would like to have raw data. When you look at raw data, when you analyze it, depending upon how you're ingrained to analyze patient information, that gives a lot of trust among the stakeholders. A very important critical part of engaging the physicians is not to value the physician's time, their commitment and effort. Time. Time is very important, because if you look at large corporate hospitals or academic institutes or people who are having small practices, they would like to look more at their patients. So if you want to bring about an improvement process, you have to justify the time taken to improve this process over seeing another patient or doing another surgery. So commitment of time is very important, and especially in larger organizations, the leadership has to be aware that this time is going to be a good return of investment for increasing the productivity of the organization. At the same time, resource commitment has to be there. Just in engaging in an improvement process, and then if adequate financial or secretarial or organizational commitment is not there, that will make the physicians not be involved and withdraw from the mechanisms. It's very easy to talk about how to engage physicians in the entire employment process, but at the same time, as a responsible physician, we too have to be careful and think what we are going to offer. So there has to be a responsible engagement in physicians in the improvement process. It's very imperative for the physicians to engage responsibly, or at least we can do as physician is at least support those who are involved. Many a time you might not be involved in the initial planning process, but later on we can adapt the change and be a part of the larger team. It's very important as a physician that we maintain confidentiality, especially when there's a government related outcomes or academic research or financial processes. So that's a very valuable thing that we have to do. A critical and very important for a physician is trust our leaders. Many a time we will have mistrust which has been built upon over the past process. Sometimes you have to move along with the teams and you have to trust both the structural and the identified leaders. And the commitment from the leaders also constant information flow. You cannot have an engagement of physicians if the information flow is not both sides. You want to engage physicians, both to and fro communications have to occur. And as a responsible physician, it's one part also that once agreed, I should support the process to the hilt. Later on, once the process has been implemented, if you want a successful one, you cannot have loud negative voices or opinions later on. What has to be done by a responsible physician in the planning period itself. So we have to be candid and transparent during the planning process. As a responsible physician, it's my job to value the process created. I should not go too much into the systems and other nitty gritty that who has been constituted in the committees, who has decided what. That say wastes a lot of our precious time. So we have to go as we build up trust to value the process that has been created. Last but not the least, we have to be flexible and open-minded as a responsible physician. Then only we can be engaged and give a more valuable support to the entire performance improvement process. I would like to conclude that to have demonstrably safe, high quality hospital care and physician performance, having consistent and continuous performance processes are an integral requirement. And engaging physicians is the key factor for success and optimum outcome measures. And this has been recognized across all the healthcare sectors. And these are the few ways that we can have a successful engagement of the physicians in the performance improvement process. With that, thank you very much.
Thank you, Doctor.
Thank you, sir.
Lot of new learnings for us. So as a summary, what are things we can recommend to promote culture among physicians, to engage physicians? So what are things I learned as per your presentations? We need to focus on culture as well as the system science. We need to create awareness about system science. What is system thinking?
Yes, sir. As physicians, we are not trained to understand what is system science. We don't take systems seriously, and
exactly
understanding the systems creates a big flaw. So any data or quality required attributes are being analyzed. We take it very personally. As a physician, anything is asked for an outcome, I'll think, oh, they're going to perform. Look at my performance, and that's a very key take-home message for all physicians. And that is something which the quality team has to initially be transparent and candid. Hey, this is not related to your performance. There are a whole lot of organizations which would like to compare X with B or C and tell, hey, this is how the performance indicator has gone about, we should do it. That has to be done in a very subtle and a diplomatic way. We should be looking at how the hospital outcome or the organization outcome should improve. Physicians as such, when you tell them about the performance indicators, we are very sensitive. And being a surgeon, that's what I would share, that when somebody tells if this outcome has been not good, with so much of ingraining in our training, we think, oh, we did a mistake, we did something wrong. That leads to a lot of mistrust, lot of initial stage denial by the physician. Hey, this is not my way of doing things, and creates a lot of friction among the stakeholders. So getting information across and putting it across is very important, sir.
Exactly, sir. And as a healthcare quality professional, we need to focus many things to engage our physicians. So, which one is the main factor, sir? Which one is we need to focus? I mean, the significant factor for physician engagement.
The most
Which
important
one
thing,
is
sir,
more
I would
important?
say
Yes,
about communication, sir. If you're
communication.
asking about an outcome, you want to improve any small process. Let us say in our hospital, we wanted to improve the cut down time between the various surgeries that we are wasting a lot of time. So involving the surgeons directly, telling them that, hey, listen, surgery A and surgery B, this is the time we lost, and tell them how much time we are wasting with the staff. If we are candid to all the stakeholders, then each of the surgeon will become more responsible and see that, hey, I can do better. It's a two-way communication, sir. As I said at the end of the lecture, it's not only engaging the physician, it's also how, as a physician, we would like to engage.
Yes, yes. And as per some research article, one of the reason for negative culture, especially from physicians. So what is the main reason for negative culture? There is no awareness about quality and patient safety. Still, many physicians not aware about the quality and patient safety. So whether we need to recommend any credential about quality and patient safety, so whether we need to recommend any credential for like CPHQ or CPPS or some other certifications, is it mandatory for our physicians?
Uh, Ideally, yes, sir. If you had asked me this question for 2 years back, sir, I would have answered it as no. But if you ask me today, yes, sir. As a physician and a surgeon, 2 years back, I would have been not very keen on getting to this thing with a simple understanding. Hey, how will it help me? But today, when I look back and when I look at how I work as a surgeon or as a physician today, I've seen a change. I've seen a process in how I think about. And what I used to think as risky or hey, this is a personal thing about me, it's changed. I look at systems, I look at process. If it's really technically and idealistically possible, yes, sir. If I would, as a physician, ask for it, ask the physicians to go at least some sort of a CPQHK training, or at least if some part of this patient safety and healthcare quality should be started at maybe graduate level, sir, so that people
Exactly.
are well aware. So you get the systems in place before you even start working. It should be a part of the
Yes, yes. So lack of awareness also one of the reason for culture, correct, sir? Why still there is no positive culture from a physician? Lack of awareness, correct, sir?
awareness. People are not educated. Not all organizations. We have to understand. I am. I can humbly say that I work in an organization where the leadership is proactive in healthcare quality. But I'm quite sure many of the participants don't work in an organization where leadership is worried about quality. Many of the healthcare organizations might be financial oriented. Now, when there is a financial or a revenue oriented, quality might take a backseat.
Exactly.
Yeah. And thank you, Doctor. It was an excellent presentation and many new ideas as to how to get a buying from our clinicians when we want to start a project. So I have two things to ask you. One is if you can give us an example of your performance indicators. You said start small, start simple things, do things which are easily doable in order to get the buy-in and get the support and to like get the ball rolling. So any example in your practice where you had started small and achieved big is one
Uh,
question I want.
yeah. Uh, I'm not going to say humbly, but I'm going to say I'm a part of the antibiotic stewardship committee in my hospital. I head the committee. What I started initially was the first thing which we started in the hospital was what we said as prophylactic antibiotic usage. Now, across the world, there is enough evidence that surgical site infections decreased drastically if you follow a proper protocol of antibiotic stewardship. Now, in our hospital, what we did was we involved the obstetricians first. Any elective cesareans, we made a guideline. We asked the stakeholders. We asked 2 or 3 key people in the obstetrics departments who are. I didn't take the top clinicians, because the top clinicians will not have time. We took the second rung clinicians, asked them to make a simple policy for obstetric practice, elective cesareans. And we circulated the document with all the obstetricians, got an approval from all of them, and we implemented it for 3 months. When we started the implementation process, we found that we reached a rate of 60 to 70%. The first flaw which we found in the system, we got back to the drawing board. Hey, why we're not getting back? Then we realized the nursing team was not aware of it. So that's a major flaw which we did from the planning team. We didn't realize the nurses can make a difference. So the antibiotic has to be procured from the pharmacy department. It has to be entered in the physician order sheet, and the nurses were involved in that. So we educated the nurses. Once we educated the nurses, we reached about 100% compliance with elective cesareans for about 3 months. So we sat down with the same team. We asked them, can we have a gynecological surgery this thing? So we went to gynecological team. Another major flaw which we did in the planning system was we didn't involve the anesthetist. Now, as of you all know, that prophylactic antibiotic usage has to be done within 1 hour of incision. So since we had not taken the anesthetist on board, we were not aware that the particular anesthetist who was the head of the department at that time, she had concerns that I will not give any antibiotic once GA is given, I might have a drug reaction. So we had to go back to literature, search for any evidence. We didn't find evidence. I can't say luckily or unluckily, the head of the department changed. So we involved the new head of department. Before involving that, we rolled out this stewardship committee gradually each department. We started with obstetrics, we started with gynecology, then we went to general surgery, then we went to ENT, then we went to dental, went to orthopedics, urology, plastic surgery. These were the specialties we had. So we took one department at a time. It has taken us about 6 years to reach 100% compliance as of today. We were struggling at 95, 96%. Again, we went back to the drawing board. Then we realized the anesthetist was still not comfortable. Brought in the anesthetist, showed them the guidelines. Once the anesthetists were confirmed, now for the last 6 months, entire hospital, I have 100% compliance. I don't have to go to the drawing board now because my process has become rigid. I don't have to change anything. The nursing staff are involved. The nursing staff supervisors who are involved in our wards, they are involved. All the physicians are involved. The anesthetist is involved. So we had 4 groups of stakeholders. One by one, we implemented it. And that's how we started on a small scale. Now we entire hospital, we have 100% compliance. I hope that's a good example.
Yeah, sir. Truly inspiring. So that's a good thing. And we have to start somewhere, basically, all of us.
Yes,
In whichever setup, yeah, that is the thing.
And I'm being honest, we struggled. We
Yeah.
had to sit down with physicians. We had 1 or 2 physicians who were not willing to give the antibiotics. That even the OR in between the timings when patients got delayed or certain surgery got delayed, the antibiotic was given in the ward. We didn't realize that. We went back, saw again the drawing board. Then we shifted to giving the antibiotic in the OR. Made a difference. But communication, every time something happened, we communicated with the person.
Yeah, so true. It's a journey and we have to begin. Yeah.
It's a journey. It has
It's a
taken me
journey.
about 7
Correct.
years to get 100% rate.
Yeah. Yeah. Very nice to listen to you, sir. Thank you very much on behalf of all my RISI team. Of course, I'm not the person who should be thanking you. Tinara sir will thank you.
No, ma'am. I am thankful to sir. I've got an opportunity to share
Yeah.
what we think. And as a physician, I have gone through a journey where I was not ready to accept all these changes. Today, I am like one of the early adopters or a champion. So I have been a laggard, changed on to the other side, makes a difference, I feel.
Yeah. Yeah, I don't know about other countries, but in our country, now certain the government policies they are contemplating if you can add a topic of patient safety in the medical curriculum. So it's not yet done, but yeah, this thought is going around that in the graduate level, they can they should add a topic of patient safety and quality. So it,
I think so. Ideally, it should be. If I
it is
look back,
there.
if I look
I
back,
don't know
part
about
of the
other
LinkedIn
countries.
today, we discuss it to undergraduate level. By the time we reach our post graduation and postdoctoral, we'll be ingrained into our head. It's a part of our training. So many of these processes don't require to be, reinventing the wheel or the fire. They're already there within us. And as
Yeah.
doctors, we are always eager to learn new things. And at the end of the day, personally, we are responsible. We have to look after our patients, and that is an important criteria.
Thank you very much, sir. Very interesting lecture. One small
Dr.
doubt I have, sir. Yeah. It's very clear from your beautiful lecture that physician or a surgeon is central to the process improvement. There's no doubt about it. The entire healthcare processes basically revolve around a clinical person, or particularly a doctor, surgeon, or a medical clinical side people, and because that's how the hospital structure is. But unfortunately, in most of the development process or improvement processes, even as a lean healthcare process management consultant, I'm just thinking that why we in our country we don't find, particularly in India, very few improvement teams or the performance improvement teams, whatever you call it, or process improvement teams, either approach the doctor or the doctor is somehow pulled into this process improvement activities generally taken up by the quality of the performance process improvement teams. Unfortunately, we don't have in healthcare organizations like performance improvement. We must call the quality department as performance improvement department more than anything else. So in this context, what measures we must take to ensure that these doctors are somehow associated with at least some of the, if not or all, as you said, we understood very clearly, as you have said, why there is a barrier between these two things, what we're trying to understand. So what measures we must take to ensure that in at least some of the process, basic process are where we can reduce time, to make them involved into this.
What you said is very valuable and very, thought provoking. That's what I would say. Now, I have worked in India only for about 10 years. In the last 15 years, I've been working in the Middle East. So the concept of how we work in the Middle East is totally different of how people work in India. Now we have to understand India is a booming healthcare sector, and with the type of organizations which are coming up, all of them have varied employment contracts. Now, to really put it in a true perspective, if you really want outcome measures or performance indicators to be really implemented, it takes a lot of courage from the leadership side. Now, given whether you're in an academic teaching government hospital, or where you're in a corporate sector, or you're in a private sector which is having multiple visiting physicians, all the three places, these are the three things that we have in India. And all these three sectors, you have to understand it's the leadership which need to have that courage. If you're in an academic teaching institute, you'll have to say, hey, this outcome measure has to be done. And the biggest flaw we'll have is how many physicians have the time to look at that data, how much of resources or people are given to that improvement process. Again, there'll be a shortage. Now, if you're going to look at the corporate world or pure private hospitals, with no offense to anybody, it is the financial outcome which makes a difference over a quality outcome. Yes. So one of the points point number 5, which put I across is the courage. The courage has to come from the leadership. Hey guys, this is what we would like to have, and this is a red line that we have.
So more than the physicians, the leadership themselves should have the education first. This education, what we're talking about.
Dr. Ashok. And if you realize, the second part of the lecture which I gave, everybody talks about engaging the physicians, but the integral part is how do physicians, we have to have a responsibility. It is not that somebody has brought an outcome, oh, it's their job, it's the quality department's headache, they are going to anyway take care of it, I am not involved. If we have that sense of not being responsible, I don't think so it's an equation which will be equal.
Okay, sir, we can wind up the session for today. If you have any more queries, you can mail to your official mail ID. So, okay, thank you again, Dr. Ramakrishna, for answering those questions and for your great presentation. It was really a pleasure to have you with us, and thank you all for attending this webinar today. And we hope that you have learned well and enjoyed this presentation. Thank you and good night.
Thank you, everybody. Good night, everybody.